Good afternoon. I can tell what you're thinking. Am I Neil's older, heavier, more short-sighted brother? And the answer is, we're not related, but the rest is true. The next thing I'd like to say is I'm very grateful to be invited to Seville. It's a lovely place. And I'm very impressed about the number of beards on show. It's a very beard-friendly audience. It's nice to see. I'm from Yorkshire in England. Hopefully people have seen a little bit of Yorkshire with the grand depart of the Tour de France this year. Yorkshire's spectacularly beautiful, so I do urge you to come and visit. I'm going to talk about physiotherapy in relation to current practice in the UK. This isn't going to be hard evidence, it's not going to be difficult science. It's going to be a nice, gentle meander towards dinner. I heard a vicious rumour yesterday that you were actually allowed beer at dinner time. I don't know whether that is true, but it would never happen in England. We can't be trusted, or we're just too repressed. Most of my colleagues in the UK feel that if you work with people with chronic pain, there must be something mentally unstable about you, and they can't see why anybody would want to do it. But we are about to enter a world of pain, so enter at your own free will. I think one of the things that's very important about trying to understand what's happening in the UK at the moment with physiotherapy practice and pain management is to perhaps understand a little bit about how physiotherapy has developed in the UK. It's been over 100 years in the making, and it's going through some turbulent times right now. So this is a bit of a history lesson. This is cultural interest. So in 1894, 4 nurses decided that they would form a society. Lucy Robinson, Rosalind Paget, Elizabeth Manley and Margaret Palmer. And they were wanting to protect the profession from some rather spurious concerns about the fact that massage had multiple and sexual connotations. So from very surprisingly dodgy roots, physiotherapy began. In 1900, the hamburger was developed in Connecticut in the USA, but that has no relevance to physiotherapy. But the society adopted a legal and public status of a professional organisation, and it became the Society of Trained Masseurs. In 1920, under its new name of the Chartered Society of Massage and Medical Gymnastics, it was granted a royal charter by King George V. Also in 1920, men were permitted to join the society. Yay! In 1944, in order to represent the broadening scope of practice, the society adopted its present name of the Chartered Society of Physiotherapy. In 1951, the CSP was instrumental in co-founding the World Confederation of Physical Therapy, WCPT, which I'm sure you're all aware of. And in 1953, the first WCPT Congress was organised by the CSP and held in London. A few years later, in 1960, the Professions Supplementary to Medicine Act, not a particularly snappy title, established the Council for Professions Supplementary to Medicine to regulate the practice. In 1968, the year of my birth, and I know you all think I look so much younger, the chair of council became a physiotherapist for the first time. Before then, we'd been dictated to by the medical profession. In 1977, a pretty landmark period, professional autonomy was established for physiotherapy in the UK. And a year later, the Privy Council had changed to agree the Society's bylaws so physiotherapists could treat patients without prior medical referral. Again, another huge step forward in day-to-day physiotherapy practice. In 1985, the gymnasts and the recreational therapists merged with the CSP to broaden and strengthen our numbers. And in 1994, the profession was totally graduate. An also important landmark in 1994 was the development of the Physiotherapy Pain Association, started by guys like Paul Watson, Louis Gifford, Heather Munsey. It was the first time that people who were interested in pain and pain management within physiotherapy had come together. And at the time, they were very, very unpopular. The CSP thought they were a real thorn in their side. They were challenging the way we perceived pain and the way we managed pain, contrary to traditional practice at the time. A year later, in '95, injection therapy came along and became part of scope of physiotherapy practice. And in '96, reluctantly, the CSP granted recognition to the PPA as a professional network. By the time we get to 2001, the HPC, the Health Professions Council, replaced the Council for Professions Supplementary to Medicine. Regulation got a little bit more stringent. And physiotherapist, as a protected title, became enshrined in law. Up to that point, people could call themselves physiotherapists by having a correspondence course with the University of Alabama, or just go on a two-weekend course somewhere and decide they were going to open up their own practice. In 2002, things really stepped up a gear in terms of pain and pain management, because Paul Watson, who you may have heard of, became the first consultant physiotherapist in the UK, and he came from a pain treatment background. 2005, supplementary prescribing rights were granted to physiotherapists, so they could now start to prescribe limited medicines within a clinical management plan. This was really a schedule with an agreement between physiotherapists and medical advisors, and it really was something that only works well when physiotherapists were working in a large multidisciplinary team, and normally with long-term conditions like pain, or like neurodisability, or perhaps respiratory medicine. 2012, because supplementary prescribing appeared to be working quite well and wasn't causing any significant problems, no nasty disasters with prescribing, then the government decided it would move up a gear and open up independent prescribing to physiotherapists. And 2013 saw that become enshrined in a change in law. So we now have courses that can offer supplementary prescribing, so limited prescription abilities, and full independent prescribing. At the moment, there are relatively small numbers as independent prescribers, but courses are up and running. So what does this tell us about how physiotherapy is now changing and where we've got to today? Well, as people have already told us this morning through some really stimulating presentations, there's a lot of things happening that we don't really understand, some things with dubious provenance, but there's a lot of things in physiotherapy that we can be happy about, but also quite uncomfortable about at the same time. The way that the training and education takes place in the UK is quite varied. There are 35 CSP approved courses. Courses are anywhere between 2 and 4 years as a mixture of full-time, part-time, accelerated learning courses, and also workplace learning. Courses remain very, very popular and are nearly always oversubscribed. And in 2012-2013, over 1,900 undergraduates qualified. However, there's always a but, isn't there? There's no standard recruitment approach amongst the universities. Some offer interviews to applicants before they make final offers, others don't. There are different interview models. There are some individual, some group, some multiple mini-interviews. Because of a lot of concerns in the UK about healthcare in its broadest sense, about losing the sort of the care ethic and the care value, courses now will have to go through some values-based testing of their applicants. But there's no particular way of recruiting. And fundamental to the way that physiotherapy now looks in terms of pain management in the UK is the wide discrepancy in how pain pathophysiology assessment and management in the curriculum at undergraduate level is pursued. And this is often variable and dependent on a number of things. Sometimes it's the level of interest within the teaching faculty themselves, or the absence of that interest. There's always been a concern that doctors and therapists get far less pain education at undergraduate level than veterinarians. Now, what does that say about our society? And clearly it doesn't set up our service well. IASP, well, they've produced a fantastic undergraduate curriculum. It's very, very detailed, it's very extensive, but it works through an awful lot of stuff. It covers anatomy, physiology, pain transmission, pain systems, animal models. It covers the psychology of pain, pain treatments in substantial depth, pharmacology, physiological methods, psychiatric treatments, interventional management and surgery, physical medicine, rehab, complementary therapy. Talks about clinical states, talks about everything you could ever possibly need. But whilst things have moved on and ideas are progressing, and IASP will undoubtedly look at the curriculum again, embracing this at undergraduate level in the UK has been very, very poor. There are about 3 or 4 universities that have anything like this model of undergraduate pain care. In terms of how we deliver pain care clinically, we have a huge scope of practice in the UK. But there's a real concern that physiotherapy has been very, very quick to embrace interesting things that push the profession in a slightly different direction, that are taking duties that were perhaps previously the reserve of medics. But we're not very good at actually relinquishing things that we think we've perhaps outgrown, that perhaps don't have any place in 21st century physiotherapy healthcare. So we've taken on a lot and not really given anything away ourselves. And the impact this has had on training is that it's broadened the curriculum, and we have to cram more and more into the courses now, which stretches the learning, and perhaps it stretches it to a breaking point at times. A concern is that there are less man hours spent on the clinical skills, refining what we do. There's also a concern that when graduates qualify, they may not be actually entirely fit for purpose in certain areas, and that's a considerable worry. It's not essential now that you do a rotation in, a placement in every single clinical area of practice. So some areas are just going to be not covered as well as they should be, if at all, and that's a concern. And particularly when our bread and butter work is managing people with pain of some description or another. We all know pain is an umbrella term. There are lots of pain problems out there, and pain patients appear in nearly every spectrum of our healthcare service. Musculoskeletal services, A&E, orthopaedics, both elective and trauma, general surgery and medicine, ITU, ICU, stroke rehab, neurology, respiratory care, care of the older person, paediatrics, learning disabilities and amputee care, cardiac care and rehab, women's health and obs and gynae. There's so much pain out there, we're not short of work for ourselves. More than enough to keep us busy. In the UK, only a very, very small number of physiotherapists work in specialised and dedicated multi-professional services. The vast majority of pain patient contact is with broader members of staff in outpatient settings. So while small teams have taken on this biopsychosocial approach in MDT practice, then the large majority of the profession perhaps hasn't moved as far with the way it views things. One of the interesting things recently was when the CSP wanted to merge a number of professional networks to make it sort of more administratively easy to manage. Then services like Mackenzie guys, acupuncture, injection therapists, sports and rehab therapists, British hand therapy services, physio-orthopedic practice and the PPA, we were put together in sort of one group after a bit of a sort of a speed dating process. And we were given the name the Musculoskeletal Alliance. And the first thing that came up in the meeting we had was that we wanted to change the term to Neuromusculoskeletal Alliance. Now, 5 years ago, I don't think that conversation would have ever taken place, let alone achieve consensus opinion. But it just shows the shift that we're actually seeing a lot more neuroscience coming into clinical practice now. But does the profession as a whole have blinkers on? I think we still look to the fact that we want to find an underlying pathology. We want to find that tissue target. In terms of the way we've learnt our pain teaching, we've often been very much spoon-fed and been told that there is this medical model and that's what we have to pursue. And although we're challenging it, and we're challenging it quite aggressively, it's only having a limited impact in some quarters. And I think the physiotherapy profession in the UK is sort of quite uncomfortable. There are some innovators, some early implementers, and there are some people who are highly resistant to taking this forward. Another concern is that the active profession is 39,500 members strong, but only 500 people choose to become part of the PPA. And that's peculiar when we think about the pain agenda at the moment. We should be the biggest professional network in the UK because of the diverse contact with pain patients. And we should be wanting to offer the highest quality assessment, management and understanding of pain we can. But that's not happening. We have something called CSP Interactive, which is a web-based forum where you can post concerns, clinical queries, requests for guidance. And it's very well supported. There are 9,000 active people who are engaging in the pain process on CSP Interactive. But why don't they become PPA members? Why don't they want to know more in a sort of formal setting? PPA has published a version of a career competency framework only in the last couple of weeks. And this has been a sort of 2-year period of work that's been very complicated. We've worked with the CSP, worked with the British Pain Society, and we've asked for worldwide opinion on this. There's a web link up there for people should they wish to have a little look themselves. What we're hoping is this will create sort of a bit of momentum with the CSP that will allow us to be able to change undergraduate teaching, to challenge the medical model and to really bring the biopsychosocial model in, to try and challenge the CSP to make all courses enforce a certain standard of pain teaching. And hopefully it'll be sort of a lever for setting out a career pathway for people who are interested in pain and want to work with patients with pain. So what are we doing about pain patients in the UK? Talked about the history, talked about the education. Well, it's hard to see what we're doing at the moment. The NHS, which is widely regarded around the world as sort of a bit of a success story, was implemented on the 5th of July in 1948. It offers healthcare free at the point of access for all the UK subjects, reciprocal agreements with other countries, and takes payment for people that are not democratically entitled to take the services we offer, but we don't deny anybody care. It's the largest employer in the UK of physiotherapists, and it's the largest employer in the UK. But it's very challenged by demands placed upon it, expectations and requirements of the public it serves. And with the credit crunch at the moment, public spending has shrunk dramatically. There are other services that are sort of now taking subsets of patients away from what was traditionally NHS care. And that includes military medical services, obviously for very particular need, care in secure environments, professional sports sector, commercial private sector through self-funding or health insurance, through public health, through charities, occupational medicine. We have something called Any Qualified Provider in the UK now, which is a scheme that was set up to bring sort of a competitive market to the provision of healthcare services, trying to drive down cost and increase standards. And therefore we could get as much as we could from the public purse that was being spent on the health service. But some physios just see pain as a very, very small part of what they do. Some people see it as the reason they are in physiotherapy. And some really don't see it as much of their role at all. If it's pain, well, they need to go and see their GP to get some medicines, or if they need to talk about their pain, well, they need to go see a psychologist. There's sometimes a lack of willingness to embrace the bigger picture. Part of this, I think, is sort of this uncertainty about sort of the quality of education staff get at undergraduate level. Part of it is a lack of confidence in themselves to be able to adequately manage what are fairly challenging, complicated patients. Part of it is their own biases themselves as to how confident and comfortable they feel about managing distress and the emotional element of pain presentation. Sometimes it's about the lack of support professionally. They just don't have any clinical peers or line managers that can give them that support. And sometimes it's just not an attractive area to work in. It's quite emotionally sapping, mentally draining, perhaps not physically difficult, but it's challenging, isn't it? You know this. So what do we offer to try and treat people with pain in the UK? Well, this is going to be quite a long list, but there are things that we try and do. Clearly, assessment is important. Physical, psychological, occupational. I think we tend to be much better at sort of looking at the tissue-based stuff, the mechanical movement model of how we assess, asking the right questions, poking the right bits, looking at the right movements. Most of the professions tend to sort of applaud how thorough we are with our anatomy and physiology knowledge. But not many people are very happy at embracing the softer skills, the more uncertain areas of pain practice. And very few people want to spend time with patients who are suffering emotionally, physically. We also don't do very much in terms of vocational assessment and reassessment, although we should. Getting people back into work is really, really important. Important for the individual, important for the family unit, important for society, and also important to get people to pay taxes, to generate funds, to keep on paying for the NHS. Advice and guidance, well, we love to provide well-meaning advice and guidance as physiotherapists, don't we? We like to give everybody our opinion. But the problem is, when you look at a lot of studies, sometimes it seems that we're patronising patients. Sometimes we're telling patients what they must do. It all becomes a little bit dictatorial. Not necessarily, we're not trying to perhaps facilitate patients to make their choices and implement those choices. And we need to get better at the soft skills side of things, which is not always what physiotherapists are comfortable in doing. But we want to create a bespoke plan of care. Lots of other speakers have mentioned it. There isn't one size that fits all. We can't cram every single patient into the same model of therapy. We have to try and work out what's going to suit them for their needs at that time, at their level of functioning, mentally or physically. But patients are difficult people. They like to do their own thing. They don't always like to do what we think they might like to do. And that can be challenging. So you've got to find common ground. We like to educate. Strong on the anatomy and physiology, strong on the pathology and the kinesiology. We like telling people what we think about this. The problem is sometimes, does this actually perpetuate the problem? Do we end up sort of over-dramatising things, over-medicalising things? Do we frighten our patients with some of this? Do we make them fearful of their own tissues? Do we create a dependence culture? Do we leave patients not knowing what the right thing is or the wrong thing is, or just really completely befuddled? If we try and do the specific pain education, well, how many of us are doing this? How many of us are looking at the neuroscience? How many of us are looking at educating patients to understand the context of pain? How accurately do we do it? What do we incorporate? What outcome does it give us? What is the most appropriate pain education? Can we agree on it? Well, no, I don't think we can particularly easily agree on it. And it's often very much at odds with what fellow health professionals are telling patients. So we're not necessarily reinforcing the same line. Perhaps we're adding to the confusion to some patients. I think Neil mentioned that if you see 1,000 different clinicians, you get 1,000 different answers. I think if you see 1,000 clinicians, you probably get 5,000 different answers, all of which do seem to be credible and appropriate, but often very confusing. And are we seen as being currently unhelpful? Are we sort of sowing seeds of discontent with our patients? Or actually are we just the flickering light of sanity in all this? Are we the people that we really need to sort of keep pushing the message to get it home, because it will change at some point? We like self-management guidance. We want to try and reduce dependence on the state, on healthcare. We want people to try and live their own lives. Some places now are getting rationing of care. So there's an artificial cut-off point, 2, 3, 4 sessions, and you'll be discharged regardless of outcome. Is that good therapy? Is that good care? If we're terminating therapy too early, what does that say about what we're doing? Does that undermine patients' confidence in our profession? Do we just leave patients to sort of self-persevere rather than self-manage? Do they just have to look after themselves because that's it? We're not giving them any skills, we're just leaving them to it. In the private sector, does that like to support people and continue dependence because there's a financial gain to that? It's interesting if we compared ourselves in terms of how we pitch our input and how we market our input and how we justify our input when we look at masseurs, chiropractors, osteopaths, sports therapists, lots of others that perhaps are sort of waiting in the wings to sort of move in on perhaps what's been seen as our core territory. Perhaps we need to get a little bit more savvy about being honest about what we do and the things that we're not doing well improve. We've got medicines. Now, again, this splits people in the UK. Some people feel that we really shouldn't be dabbling with medicines. Other people think, actually, being able to prescribe pain relief to facilitate good rehab, to reboot the momentum of rehab, is a very constructive way forward. And we do spend a lot of time with our patients most of the time. We do try and build a therapeutic relationship. Perhaps we can get better understanding of what they want from medicines rather than perhaps GPs who are very hurried, just wanting to give medicines and not really discuss all the impact and the issues. Many of us can offer diagnostic investigation, not actually doing the investigations ourselves, but ordering them. Things like X-ray, ultrasound, CT, MRI, blood tests, which tends to make sort of the movement of a patient through the service quite lean and efficient, because you're not having to go backwards and forwards to lots of different people to organise lots of parts of care. But as has been said this morning by Raphael, investigations like these are investigations of tissue integrity. They're not investigations of pain. They don't tell us what hurts. We make assumptions about what hurts. And that can be confusing for patients as well. Electrotherapy, this is a thorny one. There's still areas of practice of laser, of shortwave, of ultrasound, of TENS. But what value in this? There's a lot of talk about energy medicine and about distanced therapy, which is very controversial in the UK. Lots of people feel that energy medicine has no real part of physiotherapy at all. There's no evidence to substantiate the claims made by a lot of practitioners. But the energy medicine people are very, very fanatical about what they believe. But they need to show us the evidence, I guess. Taping, clearly this bloke has the worst job in the world. Massage and soft tissue work, well, this is often seen by patients as something that's really, really a fundamental aspect of physiotherapy. It's where it all started. But it's quite time-consuming. It's very passive. It's more and more a palliative effect treatment. And it creates dependence. But everyone likes a massage, don't they? So you can see why people keep coming back and keep asking if we'll massage them. That's a challenge. Acupuncture, well, Western or traditional Chinese. Some areas are very high providers of acupuncture. Other areas just aren't commissioned. They are not paid to provide acupuncture anymore. Joint mobilisation, motion segment manipulation, exercise prescription and progression, we'd expect these to be part of the panoply of things that physiotherapy offers. We've now got guys who are doing invasive procedure, doing nerve root blocks, epidurals, facet joint injections. Admittedly, not many people are doing this, but they are doing it up and down the UK. Now, again, people have different views on this, whether this is just a massive step way beyond what we should be doing. The risks just aren't worth the benefits of straying into this area. Others might say, well, actually, we've got really good anatomical skills. We are very, very diligent about what we do. We're quite rigorous about how we try and assess patients. Actually, if anybody's going to start injecting people's spines, why not physiotherapists? Because at least we can then prepare patients for the rehab component rather than it just being a standalone injection, which perhaps won't alter an awful lot for people. CBA, cognitive behavioural approaches. Well, there's a lot of people who resist this, a lot of people who really don't want to go down this line, a lot of people who think that it's a bit of a snub to the hands-on element of the profession, a lot of people who think that CBT and CBA are just turning us into sort of pseudo-psychologists. And now we're turning our back on the heat, light, sound of our previous days. There are a small number of people who are qualified as CBT therapists who come from a physiotherapy background, and that's a powerful combination of physical and psychological skills that can really lead to a shift in people's perception of how they manage their pain, how they deal with their pain, and how they reappraise their life with pain. But pain's not a unique individual experience. Pain radiates. It's like throwing a stone in a pond. The ripples cascade out in every direction. And you can put this slide up when we're all physios together. You see, you put it up when there's a mixed group and everyone thinks that we're slating our own profession, but everyone gets the message. There's ACT and mindfulness and values-based care. Now, this is reasonably in its infancy if you look at generalised physiotherapy practice. But there are some strong proponents of this about how people re-establish some quality in their lives. How do they get something of meaning in their lives when their lives have been dictated to by very intrusive, negative, impairing pain? But for some people, ACT is just way beyond the scope of what we should be doing. It's way off the radar. So if some parts of the profession are sort of embracing this and some parts are sort of resisting this, it creates a real conundrum in practice. There's lots of evidence to suggest that what we did with the medical model wasn't that great and wasn't that successful. Perhaps we need to amass more good quality research on the biopsychosocial stuff, but again, people look for the evidence that reinforces their own beliefs, as Neil mentioned. One of the things that I think is really interesting is the concern around the lack of perceived therapeutic ritual that's appearing in the literature now. This move towards sort of hands-off care around the world is creating a level of disappointment in patients whose expectations are that we will physically examine them, that we'll bend them, we'll twist them, we'll poke them, we'll prod them, we'll lean on a few joints, we'll make a few things pop and crack and crunch. We'll then wheel out the heavy artillery with a posh-looking machine which lights up and buzzes. If we're not doing that, people are sort of starting to think, well, what are you doing? The number of times people come back to clinic and say, I went to physiotherapy, but he didn't do anything. He just sat and talked to me. And you know that the practitioner that has seen the patient will have done a fantastic job in approaching people's concerns, fears, worries, misappropriations about their understanding of pain, but won't have done any hands-on. But to the patient, what they have perceived is they've not had physiotherapy. They've not had something done to them. And that's quite a worry for the physios in the UK at the moment. We're having a bit of a crisis of confidence in sort of what we're about and what we're trying to do, and how do we keep the public on board. Because obviously, public, if they go back to their GPs or their consultants and say, well, I'm not going to physio again because they don't do anything, they just sit and talk to me. Well, that then sends a message back to the people who hold the power base in the NHS, like the GPs and the medical consultants. There's loads of places where we offer what we do, and again, it's very, very, very diverse. But people are working in single-handed practices. People are working with sports clubs with or without medical support. There's musculoskeletal physiotherapy clinics, there's MDT clinics, there are telephone triage and advice lines, so the patient's never actually seen, they just ring up and report their symptoms and are asked a variety of questions and then given some guidance about whether they can do some exercise, do something in general, or actually they need to be seen. There are people who are working in MDT pain clinics, there are people who are working in interdisciplinary team pain clinics, there are people running pain management programs from an outpatient point of view and a residential inpatient point of view. And there are people that are providing web-based resources. So web-based resources that can sort of guide you through a cognitive behavioural approach to managing your pain. So it's small bite-sized pieces that you just absorb at your own pace. A couple of years ago, there was the first national pain audit, which looked at the diversity of pain services across the whole of the UK. Not just physio service, but sort of multi-professional pain services. Because nobody had ever done that. It was the first time it was looked at properly, about what was being offered to patients around the UK. And it was no real surprise, but it was disappointing that physiotherapy got a little bit of a hard time with that. Mainly because often many services had no physiotherapist attached to their service at all, despite it being a core requirement as seen by the British Pain Society. We also got a little bit of a kicking by the medics, because the medics were very, very quick to make clear to everybody when they promoted the results that they were the only profession that had a formal training programme in order to become somebody who was perceived as being appropriate to treat pain patients through the Faculty of Pain Medicine. What they sort of carefully overlooked was that 90% of the people that are in the faculty have been grandfathered in through experience. They haven't done any exams or any extended learning. They've just been doing the job and they were adopted into the faculty. But this made us really think in the PPA about where we were going with things, and it sort of worried us, and we thought that we could be really worried about being dictated to by the medics, who would then tell the profession what they thought we should know and what we should be doing with our patients. So this led to sort of looking at the career competency document. So how do we make change? Well, the CSP is lending its weight to the pain agenda in the UK. The pain agenda is going up the agenda politically. Unfortunately, it collided at the same time as a shrinking public health spend. But more and more people in positions of power are aware of the issues of pain, chronic pain management, under provision of services. Physiotherapists don't have to become members of the CSP, though. They can practice perfectly reasonably without being members, so they don't access things like the professional networks. The British Pain Society only has less than 100 physiotherapists as part of its membership. It's very medically dominated, but we do have 2 members on council. And then the IASP, the North British Pain Society, NHS England, AHP services in the UK, and also WCPT Pain Network, can all try and be positive instruments in moving the agenda forward, challenging out-of-date care, promoting good areas of practice, promoting areas of good quality evidence, and trying to exchange sort of problem-solving approaches in other countries, sharing information about how we go about tackling these patients. Because after all, physiotherapy is pretty safe, pretty high quality most of the time. There's a few other things we can throw into the mix. Political lobbying, leverage, or expediency, just trying to say the right thing so we don't step too far out of line. An academic change, getting rid of the medical model and really embracing the biopsychosocial, not just giving lip service to it. Fast-tracking sort of the pain science into clinical practice. We're quite conservative as a profession. We change our ideas quite slowly, don't we? Sometimes we can get a little bit hung up on evidence-based medicine, and actually perhaps evidence-guided medicine would be a better way sometimes. If we're waiting for the perfect trial on a large enough size to demonstrate perfect efficacy, we're probably going to be waiting forever. Legislation often changes things, like the independent prescribing. An unashamed plug for Louis Gifford's work. I'm sure many of you are aware of Louis, who sadly died in February. His wife has published the last of Louis's writings. It's called Aches and Pains. It's a fantastic 3-volume set of work. Louis never really sort of pushed a particular line of therapy. His approach, though, was to listen to the patient properly, actively engage in listening, work out what that patient needs. So, great book. Strongly advise you to look at it. Networking and social media. Well, I'm afraid I'm very old-fashioned. I don't do Twitter. I'm hopeless. But social media will influence everything. Expectation management, really challenging. Patients are better informed when they come to see us. They're better clued in about what they want from us. They're telling us what they want from us. They normally know what their rights are about how they get what they want from us. And that can be quite uncomfortable for us as professionals. And perhaps we have to adapt and survive, or resist and die, because the profession won't stay still. And finally, thank you to the organising committee for organising a wonderful couple of days, and their kindness to the speakers. Thanks to you, the audience, and thanks to the guys in translation and interpreting services to try and make the best of my horrible Yorkshire accent and make it legible to you guys. Thank you.